longer for them over time if these are going to be long-term patients. So first and foremost, what is parenteral nutrition? It is the administration of intravenous nutrients, macronutrients, micronutrients, electrolytes to patients whose gut cannot be used for feeding. First thing to note is it's most important if we can use the gut, it is essential that we do so. However, there are situations where we just cannot. For instance, post-op surgical patients, high output ostomies, malabsorptive type syndromes, congenital GI anomalies, where you just cannot feed the bowel. So these would be potential indications where you would want to use parenteral nutrition as a source of nutrition. Now, how does this apply to premature infants? As Charla kind of alluded to in her presentation, it can take 5 to 10 days, if not longer, to meet 100% of these infants' nutritional requirements through the gut alone or enterally. We usually do for infants less than 1.5 kilos, minimal enteral feeds, just trophic feeds, non-nutritive with hopefully mom's milk. For at least 24 to 72 hours as clinically needed. We'll continue that longer if we need to. Now, on top of that, once we do finish that period, once we start slowly introducing more and more enteral nutrition, it may take another 5 days to reach our goal fluid intake volume, along with fortification, which may take another day or two depending on tolerance. So because premature infants, they have such poor nutritional scores and their energy and protein requirements are so high, they're at very high risk of malnutrition, which could compromise their outcomes, both in hospital and later on in life. So we opt to start parenteral nutrition as a supplement very early on in life. So first thing to consider when starting parenteral nutrition is what is your IV access? What is that going to look like? So we have two sources. First, the peripheral, which are usually for short term. It's very difficult to meet nutrition requirements with a peripheral line, especially with a fluid restriction. This is because the osmolarity of the TPN has to be less than 900 milliosmoles. And that is not really optimal for the high needs of these premature babies. For myself, what I kind of go by is we can put up to 3% amino acids and up to about 12.5% dextrose in here. If we are able to have a T5 at least 135 to 150 mils per kilo, and all of that is dedicated to TPN, we can usually do pretty good. But anything less than that, we would severely compromise the nutrient provision. So if we are having fluid restriction issues, or if we need something more long-term, central lines would be great. With these, they're more robust. We can easily meet 100% of their energy requirements and other macronutrients and micronutrients. Comparing the two with concentrations, we can add to 5% amino acids and more than 20% dextrose, although we don't necessarily do that too often. It just depends on how much fluid we have to work with and other potential infusions. So starting with the energy requirements, there are many components of this, 5 components. Your basal metabolic rate, activity, growth, diet-induced thermogenesis, any correcting of any pre-existing malnutrition, for example, if the baby's IUGR or SGA, maybe not SGA, but any kind of growth restriction in utero. Would be at more risk than an appropriately for gestational age infant. Also to consider any significant disease state that may also increase energy expenditure, for example, heart failure or potential PDA or anything else that may make the baby expend more calories as energy. Now, to meet these energy requirements, we need to provide a proper balance of lipids, amino acids, and dextrose. An inadequate ratio of these kinds of things can lead to altered metabolism and unfavorable outcomes, specifically with the liver. But when it comes to total energy requirements, for this presentation, I'm going to focus primarily on the first couple days, week of life, because that is when things are changing the most. But for the first day of life, we want to provide at least 45 to 55 calories per kilogram per day from a combination of lipids, amino acids, and dextrose, and progress gradually to provide about 90 to 120 calories per kilo per day. It's important to note that these energy requirements, it's very difficult to accurately measure energy requirements in newborn, mostly because the gold standard of measuring this would be through indirect calorimetry, but it is relatively inaccurate. A lot of what the recent studies are doing, a lot of the information I've taken from today's presentation is from the 2018 European Society recommendations for parental nutrition for infants and neonates. But what a lot of the studies have done has just subtracted about 10 to 20% from the enteral requirements, just to bypass digestion, absorption, and metabolism and the energy associated with that. But aside from these requirements for parental nutrition, it's also very important to note other sources of nutrition, which may be enteral feeds or tube feeds or oral feeds, if this is an older child or infant consuming something by mouth or by tube, and also potential other infusions that may contain dextrose or lipid. Now, when it comes to prescribing energy intake, it's important to try to avoid overfeeding and underfeeding. As I mentioned, with an imbalanced TPM prescription, overfeeding and underfeeding also has its risks. So for excessive energy intake, you can run into issues with hyperglycemia by providing too much sugar, impaired liver function, for more prolonged TPN with both fat and excessive glucose or dextrose administration. Also abnormal metabolic programming. If there's just an overall excess of energy intake over time, this can lead kids to developing metabolic syndrome later on in life. On the flip side, inadequate energy intake, as you would probably expect, poor growth, poor accumulation of lean body mass, and subsequent impairment of neurodevelopmental suboptimal neurodevelopment over time. And also, maybe most importantly for us, is impaired immunity, because these babies also already have an impaired immune system. This can just exacerbate that by providing poor nutrition. One thing that's not mentioned here is adequate nutrition can also just overall improve, I think, outcomes of global outcomes, just with proper growth, development, and healing. So the first macronutrients that I'll talk about is lipids. There are a number of commercially available lipids, IV lipid emulsions for hospital use, but I will only talk about 3 today that we use here. There's a 4th one available. It's a soy and olive oil emulsion. I think facilities in the USA use that. I don't think any of my colleagues across Canada do currently use it. But IV lipids are about 10 calories per gram compared to about 9 calories per gram for our food fat that we consume. But it's important to note that the IV lipid emulsions that are available are not made equally. So the one that is probably one of the oldest is the soybean oil. It's at 3% concentration. It's 100% soybean. It is relatively pro-inflammatory. It has a relatively high omega-6, omega-3 ratio. It's very low in vitamin E, so the pro-inflammatory aspect is from there. It's also very high in phytosterols, so it can be very difficult on the liver as well with a high cholesterol load. So because of a lot of these, it has been shown to result in cholestasis for long-term use. So it's not recommended for use for more than a few days if possible. Another one of the lipid emulsions available is fish oil. This is a little more dilute, 10% concentration. It is essentially a complete contrast of the soybean oil. It is less pro-inflammatory, so it has a lower omega-6, omega-3 ratio. It's very rich in vitamin E. The issue with this is the max dose that we can provide is about 1 gram per kilo per day. So we usually have to combine it with another lipid, usually the soybean, to meet your essential fatty acid requirements. Otherwise, we'd be at risk of deficiencies. This has not been proven to prevent cholestasis, but the usage has demonstrated faster reversal once we have developed cholestasis and to not necessarily treat it, but get past it. The issues that we have here in Canada is before we can use it, we have to obtain special consent from, I think, Health Canada prior to using it, but we haven't used it over the last number of years that I can recall. Because we have started using a relatively newer emulsion, a mixture of soy, medium chain triglycerides, olive, and earlier about the medium chain triglycerides in IV lipids. This contains about 30 medium chain triglycerides, 30% soy, 25% olive, and 15% fish. So this is a very nice blend. I would say almost like a neutral profile. It's got a very close omega-6, omega-3 ratio to breast milk. And we are very easily able to provide enough of this lipid to prevent fatty acid deficiencies, such as fatty acid deficiencies. There is also some newer evidence saying that it may help in reducing the incidence of retinopathy, prematurity, chronic lung disease, and cholestasis. But these babies are not usually on these lipid emulsions or parenteral nutrition for that long, maybe more so your chronic ones. But when you're starting out for the first day to 2 days of life, you want to start a continuous lipid infusion within the first 8 hours of at least 1 to 2 grams per kilo per day. The evidence says you can start a little bit higher, but you will likely run into issues of hypertriglyceridemia. We ourselves start at 1 per kilo per day and follow triglycerides and daily to monitor tolerance. And we increase by about 0.5 to 1 grams per kilo per day to our goal rate, which is usually about 3 grams per kilo per day. Again, in the most recent literature, the max intake is about 4 grams per kilo per day. Us here, we have never gotten that high or had a need to go that high. We usually stop at 3, but there is the option to increase if necessary. But one thing to note is your lipid intake should make up about 25 to 50% of your non-protein calories. So the next macronutrient would be dextrose. Dextrose compared to oral carbohydrate is 3.4 calories per gram. Same as your D10, D50, and D12.5 infusions. It's the same 3.4 calories per gram. Carbohydrate or dextrose should make up about 40% to 60% of your total energy intake for these babies. It should be guided by the balance between meeting your energy requirements and the risk of overfeeding these babies. Only your lipid and your dextrose should be used to titrate your calories up and down to meet your energy goal. But you just don't want to provide too much because you will run into issues with hyperglycemia and excess lipogenesis. Also consider the phase of illness. If the baby's acutely ill, glucose metabolism may be a little bit altered. You could run into issues with hyperglycemia. Also within the first days of life, you could have issues with the baby being hyperinsulinemic, having hypoglycemia episodes, or the complete opposite, hyperglycemic. Also things to consider are your micronutrient supply. You also need sufficient calcium, phosphorus, magnesium, potassium, especially if there is any early refeeding-like syndrome with these very small babies. With regard to overfeeding, the maximum glucose oxidation rate of the liver is about 12 milligrams per kilogram per minute. So we try not to exceed that if we don't have to. There may be the rare case where we may have to do that acutely for a little while. But with TPN, just for nutrition purposes, usually less than 12 milligrams per kilogram per minute of a dextrose infusion is adequate. This is just, again, reduce the incidence of hyperglycemia, lipogenesis, and insulin resistance. Also to note, we tend not to start insulin right away on these kids. We tend to wait until their blood sugar is creep up above 10 millimoles per liter. Just because once you start with insulin, you're at risk of these babies becoming hypoglycemic, and the risks of hypoglycemia are a little bit greater than a little bit higher of the blood sugar. So we tend to wait on this and not get too aggressive. And there really is no evidence in the recent literature, from what I'm aware of, or at least the recent guidelines for tight blood glucose management, again, because of the issues of hypoglycemia. So what do we do? On day 1, we usually start with about 6 to 8 grams per kilo per day of dextrose. The fetal glucose infusion rate is about 5 milligrams per kilogram per minute. So this is about equivalent to that, the 8 range. What we do is myself personally, when I come in the morning, if the baby's born overnight, I look at what IVs are infusing, how much sugar they're getting, and what their blood sugars are like, and I will dose. Myself, the pharmacy would give them kind of a very similar glucose intake as to what they're already receiving. Now, over the subsequent days, as depending on how things go and how they tolerate the dextrose, we would try to increase by about 1 or 2 grams per kilo per day, again, pending tolerance, to a goal usually of about 14 to 16 grams per kilo per day. But again, that 12 milligrams per kilogram per minute is about 17, 18 grams per kilo per day. We very rarely have to go that high. Now, the next macronutrient, the final macronutrient would be your amino acids. They provide about 4 calories per gram. The parental requirements for amino acids, according to the most recent recommendations, are lower than enteral nutrition. Enterally, we could require about 4 to 4.5 grams per kilo per day, which is quite high. But for parental nutrition, it bypasses the digestion, absorption, and metabolism that happens in the gut. And therefore, they have said that we don't need to go any higher than about 3.5 grams per kilo per day at the most. It's important to start your amino acid infusion as soon as possible, just to avoid accumulating a nitrogen deficit, a negative nitrogen balance, and start proteolysis, taking the body's own protein for energy. Again, for appropriate accumulation, accretion of lean body mass, we need some substrate to facilitate that. So you need at least 30 to 40 calories per 1 gram of amino acid to help build that protein and build that tissue. And as I mentioned before, try not to dose, don't dose your amino acids to increase your energy intake. Only dose your amino acids for protein requirements. Although they still are counted, the 4 calories per gram is part of the total energy intake. You should be considering your glucose and your lipids as tools to increase your total energy intake, but again, as long as they're balanced. And finally, it's relatively inconclusive whether high amino acid intakes results in a high blood urea nitrogen. I believe in utero, the baby oxidizes a lot of amino acid, and it's uncertain whether what level is too high of blood urea nitrogen once we start basing our protein doses on that. I absolutely see low BUNs quite frequently on babies who I know are not getting enough protein, and we can, as we follow the electrolytes and renal function, we do see those numbers increase, the BUN increase. But the question is, I don't think we really know just yet what number, how can we quantify a high blood urea nitrogen? So for the first day of life, again, start as soon as possible. Us here, we have a basic start TPN solution, which can be run at 40 per kilo through an IV as soon as the baby's born. It provides about 10% dextrose and about, it is 10% dextrose, 5% amino acid. That's why we don't run it at the full TFI. So it usually provides about 4 grams per kilo of dextrose and about 2 grams per kilo of amino acid. We will kind of work our way up for that once we actually do send our TPN to the compounding pharmacy, as we would with the full script. But the first day of life, you should be giving at least 1.5 to 2.5 grams per kilo per day, and adjusting by about 1.5 to 1 gram per kilo per day thereafter. It's a goal between 2.5 to 3.5 grams per kilo per day. Now going into the electrolytes. I'll start with sodium. Now, within the first couple days of life, fluid restriction has been shown to have a positive effect on your oxygen requirements and later risk for bronchopulmonary dysplasia. However, this fluid restriction can also put the patient at risk of hypernatremia. And a quick correction of sodium, whether from high to low or vice versa, may impair later neurocognitive outcomes. So be very careful with that. We usually try to minimize the sodium that we provide in the first couple of days of life. However, because of the chemistry with our TPN pharmacy, sodium usually has to be binded to something. So we usually have to provide I should take that back. When we try to provide calcium and phosphorus, those usually have to be binded to something. And so we usually have to provide a little bit of an inherent sodium or potassium to begin with. We try to minimize this as much as possible. Now for potassium, you can have this refeeding-like syndrome in your very low, extremely low birth weight infants, especially your intrauterine growth restricted ones. So you would see hypophosphatemia, hypokalemia. So again, be cautious with what you're giving. You may require a little bit more potassium than usual. Also, on the flip side of that, you may see hyperkalemia just with premature kidneys. So keep an eye on your blood work. So recommendations for the first couple of days of life, as I mentioned, until the initial fluid shifts occur and you're able to fully diurese the infant. Your sodium requirements are about 0 to 3 millimoles per kilo per day, and they will increase to about 2 to 5 millimoles per kilo per day, or 2 to 7 millimoles per kilo per day for those who are a little bit smaller than 1.5 kilos. But again, you can kind of titrate these based on whatever your lab results are that you see. Potassium is very similar, again, until that extracellular fluid contraction occurs and completes. You want to minimize your electrolytes that you're providing, and over the coming days, they will require a little bit. So calcium, again, these are your calcium and phosphorus are based on fetal accretion rates and total body ratios. So the fetal accretion rate of calcium is about 3.4 millimoles per kilo per day. You may experience rapid hypocalcemia within the first day or two of life, but this is just related to the immaturity and delayed surge of parathyroid hormone with that abrupt after birth, that shock, and that brief immediate cutoff of calcium. As for phosphorus, the fetal accretion rate is about 2.6 millimoles per kilo per day. It's important to note again for in some of the recent studies, I think this is one by Aspen, they quoted that they need at least 1 gram of protein for that to be muscle accretion. You need at least 3 millimoles of phosphorus. This almost seems like a bit of a refeeding-like syndrome as well. This is again in very low birth weight infants. I'm not too sure if this was the glycogenic amino acids or if there is in fact a refeeding syndrome associated with protein provision. Usually it is associated with carbohydrate, but they have recommended at least 0.3 millimoles of phosphorus per 1 gram of protein in the TPN. Total body calcium to phosphate ratio is about 1.3 to 1. Within the first few days of life, you will likely need to provide more phosphorus than calcium, so this may be a ratio closer than 0.8 to 1.0, but keep that in mind. It's very difficult, again, to meet your calcium and phosphorus needs with parenteral nutrition. The ratios are difficult, compatibilities are difficult, and babies just tend not to tolerate without becoming hypercalcemic. So along with that, monitoring bone mineralization over time is very important. Magnesium, the fetal accretion rate is about 0.1 to 0.2 millimoles per kilo per day. This equates quite nicely to the parental requirements as well. But it's important to note, especially over the first few days, did mom receive any magnesium sulfate? This can significantly increase the baby's serum magnesium. So you will, again, along with kidney function, want to withhold any magnesium for the first few days. So kind of as mentioned above, those are the requirements there. We tend to start these right away, especially in the small babies, at least 0.5 to 0.7 millimoles per kilo per day of calcium and phosphorus, and titrate up there as such. But again, I still try to provide at least 0.3 millimoles per gram of amino acid that I provide. And again, your magnesium too. Going into trace elements and vitamins, these are a little bit tricky for us to deal with because they come dosed in vials. So it's very difficult to dose individual ones. If we want to provide more vitamin D, for example, we have to give more of all of the vitamins. We also give more vitamin A, vitamin C, all the B vitamins. We can't just give more vitamin D. So if we have special protocols with our pharmacy department to meet all of the requirements for these, for both the trace elements and the multivitamins. Deficiencies of the multivitamins is they do contain an adequate, more so with multivitamins, trace elements, they do contain inadequate amounts of zinc, copper, and selenium. It also does not contain any iron or molybdenum. Molybdenum, however, is a common contaminant of TPNs. We will inherently meet our needs with that. We may not consider that, but it's there. Aluminum is also a very common contaminant, but more so associated with glass vials. I know a previous calcium supplement, parental calcium supplement, was associated with high aluminum content from the glass. So we've moved away from that over the past number of years. But with those deficiencies, we are able to correct them through some single dosing. We can single dose the zinc, selenium, iron, B12, vitamin K, and although not a vitamin, carnitine, but just to facilitate with lipid metabolism over time. Zinc, we start as a protocol to top up our zinc intake from within the first few days of life whenever we do start the multivitamins and the trace elements. Selenium, we can also dose as we needed. Iron, we don't usually consider for the first few weeks of life, again, because babies can start to become anemic by about 4 to 6 weeks. But we do look into that. We do check levels routinely. Vitamin B12, more so for short bowel syndromes, those missing their ileum, and vitamin K as well, which is already inherent. We can give additional if necessary. If there are any hepatic issues, vitamin K metabolism is there. So monitoring, there's a lot to monitor. Our standard blood work until stable whenever we start TPN. This applies to babies both born right after birth if we start TPN, or those who start later on in life. For elaborating from Charlotte's talk, those who may require TPN for 2 weeks, this kind of protocol follows them too. But we do blood work for the first at least 2 or 3 days until their blood work is stable. We do have kind of tweaking our electrolytes to be stable, and also titrating up on our energy intake through our protein, our amino acids, dextrose, and lipids. We monitor kidney function, any kind of acid-base issues. If we are providing too much chloride in the TPN, it can become a little bit acidotic, so we can substitute that with acetates. Triglycerides for lipid metabolism, and albumin. Blood glucose is also checked quite routinely, especially in the first couple of days of life. But whenever a baby is on TPN, or a patient in general is on TPN, we should be doing a point of care blood. Nursing should be doing a point of care blood glucose at least daily. Liver function tests we do once a week, including a bilirubin, total direct bilirubin, ALT, AST, GGT, and alkaline phosphatase. CBCs as needed. Other monthly, more long-term TPN, we don't get a lot of patients like this in the NICU. A lot of these patients by this time would have possibly gone to the ward. These are usually your long-term GI anomalies, short bowel syndrome, maladaptive-type conditions dependent on TPN. We follow parathyroid hormones, vitamin Bs for bone mineralization, especially in your premature babies, INRs, for if there is any liver issues, along with your trace elements, because they're the risk of deficiencies, especially with selenium. Zinc is also another one, because we are single dosing that one. We also can single dose selenium as well. Copper and manganese as well, that can become quite toxic if there is any issues with the liver. We also monitor, surprisingly, the dietitian has not spoken too much about growth yet, but we do monitor daily anthropometrics. Nurses do weigh the babies daily. This is for babies on TPN or on full enteral or oral feeds. We weigh them daily, follow their growth very closely on the growth charts. We monitor their head circumference and length weekly, just to watch for adequate brain growth, head growth, and length growth as well. We also, I didn't talk enough about this today, but this is a very large topic, but adjusting their parenteral nutrition intake for their enteral intake as well. So we do closely monitor while they're working up on their protocol, feeding protocols. We're adjusting the TPNs accordingly to make sure that we're not overfeeding or underfeeding them. So we will gradually titrate down on their protein, amino acid, and dextrose, or sorry, protein, lipid, and dextrose intake over those coming days, along with any other IVs or medications that they may be receiving. But just to note, with the protocol feeds and the TPN, parenteral nutrition, we do try to get all lines out as long as it's safe to do so. By the time the baby's consuming at least 120 mL per kilo per day of enteral volume, we may be a little bit reluctant to do so on those kids with malabsorptive type conditions, because they will be more reliant on growth from the parenteral calories. But if it's just a standard protocol type newborn working up on feeds, doing well, the lines, just an infection risk, the lines come out once they're consuming about 120 mL per kilo per day. Common complications of parenteral nutrition, just to touch on these quickly, electrolyte abnormalities, especially within the first week of life. Or even later on, just with inadequate intakes or changes in metabolism or physiology. Infections, I have line and blood infections here just associated with these long-term lines. Nutrition too. Drug incompatibilities, I'm not going to go into this. This would be a better question for pharmacy, but there are a lot of incompatibilities with some antibiotics and other medications with parenteral nutrition, both the amino acid dextrose solutions and the lipids. Hypertriglyceridemia with lipid infusions, even potential excessive glucose intake. Hyper or hypoglycemia, again with sugar intake. Acid-base disorders, phlebitis. This is more so associated with your peripheral lines and excess osmolarities in the TPN, parental nutrition-associated cholestasis, and liver disease, or just those babies on long-term aggressive parental nutrition, or maybe if parental nutrition is their sole source of nutrition. Enteral nutrition alone, just even just a little bit, is enough to help prevent or reverse this. Essential fatty acid deficiencies, depending on what lipid emulsion you do have available, and other metabolic complications and osteopenia and prematurity, and even more vitamin mineral toxicities just with the components of the currently available vitamin and trace element mixtures. So just to briefly recap here what we do over the first few days of life, this is kind of our standard TPN protocol. On day one, we usually try to start with 2 grams of amino acid or protein. SMOF, we give, that is the soy medium chain triglyceride olive and fish oil composite emulsion. We start with 1 gram per kilo of that. Dextrose between 6 to 8 grams per kilo per day, and we increase by about 1 to 3 grams per kilo per day thereafter. Sodium, again, we try to minimize, but we may need to put a little bit in inherently just for compatibility issues, and along with calcium and phosphorus, and a little bit of magnesium. Vitamins and trace elements and zinc, we usually wait 2 or 3 days, but we do start that by the first few days of life. Some of my references, and that is all that I have. Thank you very much.